Hi, welcome to the final exam practice exam. If you haven't done these before, this is how it's going to work. We're going to move through all three modules that are covered in the final exam, and these slides are going to have reviews of the content. So there'll be a bony soft tissue slide, a bony anatomy slide, a soft tissue anatomy slide, and then kind of key areas of injury. Sometimes we might have movements and emotion slides. These are going to cover what the study guide emphasized for each of the modules, and this is going to directly correlate to the content that is on the exam. On these slides, you'll see blue dots. You want to click on those blue dots immediately and it will stop the video and it will ask you the question and then you will answer it. I highly recommend that you do that right away and you just get a gauge on how well you know that content and how confident you feel. Then you can always, and then when you're done, you just let go of it. It'll continue playing the video and I will explain then the answers to the questions or the content that is covered. Or not all of the questions will be directly, like there may be more questions on the exam that aren't directly covered on the exam or on this practice exam, but I will be talking through a lot of the content that is covered. So be sure you're listening. It's recommended to take a note sheet while you're going through this and kind of highlighting the areas that are covered in the questions. In those questions, it will give you some feedback of where to go find it, but you should always go back to the module and look there. These videos are really brief. I don't have the anatomy models that I had when I originally recorded these because I had to borrow those. So it's always better to go back to the initial videos that I made and get the content there and then come back. If you're still having questions, please make sure you reach out. So we are going to be covering hand, wrist, and elbow, and then shoulder, and then spine. And something else you need to know about this exam is that there'll be just a few questions that are kind of comprehensive to all of the content in the class. So it might provide a bunch of injuries that could be outside of just these injuries from these modules, and you'll have to identify like which one was from which mechanism of injury and things like that. So at the end of this practice exam, I'm going to give you some tips and tricks on how to break down those questions and how to answer those, and we'll practice one. So for the hand and wrist and elbow anatomy, what we really need to focus on here is making sure that you can identify where the radius is and where the ulna is. So this first picture is really classic where when you pronate the wrist, it makes the radius and ulna crossover. So you always want to remember the radius lines up with the thumb. I think about it as the thumb can do radial motion, go in a circle. So it lines up directly with the radius. And then the radius in anatomic position is going to be on the outside of the elbow where it lines up with the radial head. So when you, the radial head is at the end. So you want to find that radial head that looks like a disc at the end. And that is the radius. And then you find it where it lines up at the distal end by the thumb, and you want to follow it all the way back. That's how I orient myself with the forearm. I always just find the radius first because it's so distinct in how it looks and where it lines up with. And then when you're talking from the elbow point of view and you have a picture of just the elbow, the radial head, which is that little disc there, you see radius labeled, and then you're going to see the radial head, it lines up with a capitellum. So that piece on the end of the humerus that lines up with the radial head, it looks like a little ball almost. That is the capitellum. And then on the other side where it says ulna, that is where you have your coronoid process. It meets the trochlea. So the trochlea is the end of the humerus that almost looks like a crevice there. And the coronoid process from the ulna rides over that trochlea. And then the part that sticks out the end of your elbow is your olecranon process. Please go back to the video if this is confusing at all to you that I made from module 9, which has the anatomy model and will point it and explain it, or go back to your APR assignment. But that is probably the most confusing part, is the elbow itself. And then when we talk about the hand, remember the little bones inside here, the irregular shaped bones are called your carpals. You have 8 carpal bones, and then you have your metacarpals, and then they meet your phalanx, your phalanges. So we have, when you're talking about your joints, and we're talking about our MCP joints, so our metacarpal phalangeal joints are right here, and then our IP joints are inner phalangeal joints. So just remember that you understand the differences in those. When we go to muscles, there's a lot of muscles that connect and cross the wrist and go to the elbow and attach there. So it gets a little confusing. So all I've asked you to really understand on for this section is the difference between what attaches on the lateral side of the elbow and what attaches on the medial side of the elbow. So on the lateral side of the elbow, you have your extensors and your supinators, which are going to be on the posterior side of the arm. So these are going to be your extensors. They're your wrist extensors, your finger extensors. They come all the way down the posterior side with your supinators. So they pull your hand up. So supinators and extensors are together on the lateral side, and then your pronators and your flexors are on this anterior side, anterior medial side, and is going to come down and attach to the medial side of the elbow. So those are the main things you need to take away for those muscles. When we talk about key areas of injury, there will be questions about particular injuries from Module 9, not Module 6, but Module 9, that will be associated with these types of mechanism of injury. So the first thing I want to talk about is this person falling on an outstretched hand, and that is foosh, F-O-O-S-H. That is fall on outstretched hand. And there's two different set of injuries that we expect to happen between a pediatric patient and an adult patient. So when you fall, that energy travels up the arm, and a lot of things can happen at the wrist, the elbow, and the shoulder. It's typically going to find the weakest point. Also depends on how you fell, how fast you fell, what you fell on, a lot of different things, right? But if it's a pediatric patient, it's more likely to be bony injury, where if it's an adult, it's more likely to be soft tissue. And that's because the bone is the weakest part in a child. But as we get older, it's nice and strong, it's really dense, it's not as spongy, and the soft tissue is likely to fail. So in a pediatric patient, there might be a question that's asking, what is more likely to happen in a pediatric patient? You want to look for those bony type of injuries. So distal radius fracture is a thing that most likely to happen in a child, and then an elbow fracture, which would be supracondylar fracture. So you have those condyles on your humerus, and it's just right above that condyle. Right here is a weak spot in a child. So supracondylar fracture, distal radius fracture. And in an adult, we're looking at shoulder dislocations, and looking at sprains and strains, and not necessarily fractures. So we would also be looking at what we call a TFCC tear in the wrist. So TFCC tear, on a collateral ligament tear, shoulder dislocation, those are all more common to happen in adults for a fusion injury. And then the middle one here is talking about Quervain's tenosynovitis, which was one of those key areas that we focused in on Module 9. And so this is where you have your extensor pollicis brevis and your abductor pollicis brevis. So it's the two muscles that are pulling your thumb out. So it's abducting and extending back. And as you can see in that picture, it's running through one dorsal compartment there, the first dorsal compartment, and it's tightly with it has a little tunnel from the retinaculum. And when those muscles get really swollen, that creates pain in that area. So it's a very common place where I've had this before. It's common in young mothers or new mothers that are constantly holding their kids, and they're constantly in this position where their wrist is back and their thumb is back holding their child in a hip sit position, or taking them out of a crib with their thumb back. And so that area gets really hurt, and it can often feel like something is broken. So it's important to know about that injury. And then the one all the way over to the right, it's showing you a valgus extension overload, which is just common, like whenever pitchers, when we're in this position, we're gaining torque and we're in this extended position, or when we're constantly landing in a weight bearing with gymnastics, what areas are really injured or compressed, or stretched out with this type of injury. So you look at this picture, and this is in max extension. So the radiocapitellar joint, where that radial head meets the capitellum, it gets compressed along with the olecranon in that fossa, the olecranon fossa. Those two areas are getting really compressed. So it's back in extension, it's really pushing on them. Where that medial part of the elbow, where that would be where those arrows are pulling apart like that, and it's tension, that's the UCL ligament, the ulnar collateral ligament is there, and there's a lot of tension on that ligament. So that is, so you're worried about tension on the UCL and compression of the radiocapitellar and the olecranon fossa area. Moving on to Module 10 with the shoulder anatomy. So make sure that you know where, be able to look at this at different angles and know exactly where you are. So on this first picture, you see the scapula, but are you posterior, are you anterior? So you see this bone protruding out towards you. That blue area is the glenohumeral fossa, glenohumeral fossa, where the glenoid is. This is the glenoid, and then or the glenoid fossa, and then the humerus will come in, and that makes the glenohumeral joint. So your glenoid fossa, and then the bone sticking out over it, coming towards you in the picture, is your coracoid process. So when you see the coracoid process coming out towards you, like over top of that glenoid fossa, that's how you know we're looking at it from an anterior view onto that. And then you look above that, you have the clavicle meeting the acromion. The acromion is coming from the scapula, from the posterior side and around and attaching, making that AC joint. Please go back to these videos from the anatomy and go back to your APR assignments to review these and make sure you really understand where that is, because there will be anatomy pictures asking you where the coracoid, where the acromion is, the glenoid fossa. Make sure you understand those, because the humeral head is pretty obvious. You can see that, but you really need to understand the rest of the shoulder girdle there as well, and understand where the clavicle is that comes across. So when we talk about the different joints of the shoulder, we have our AC joint where the acromion and the clavicle come together. We have our sternoclavicular joint, or SC joint, right here. And then you have your glenohumeral joint where your shoulder, we reference to be our actual shoulder, where this is the glenohumeral joint where our humerus meets the glenoid fossa. And then when we're talking about muscular anatomy, it's just really important to know the rotator cuff. So this second picture with the red muscles on there, understanding and be able to find yourself anterior versus posterior. So when you're looking at the two pictures with the scapula with the red muscles, the first one on the left, and it says anterior view, we know it's anterior because you can see the coracoid coming towards you. You can also see where that clavicle is meeting the acromion there. If you're also paying attention, you can see that supraspinatus coming in through the back. So our rotator cuff muscles are our sits muscles, SITS, supraspinatus, infraspinatus, teres minor, and subscapularis. So on this anterior view, you're seeing the supraspinatus coming from the back, and it's coming over the shoulder like this and attaching in. That's your supraspinatus. So if you're looking at the spine of the scapula, supra is above, and it's coming in above the spine of the scapula. And then subscap is under, so sub is under, so under the scapula. So on this anterior view, we're seeing that big subscap there. Normally we wouldn't see it because the actual thorax is, in front of that, so we wouldn't see it. So this is a great view. The posterior view we would be looking at, so if you've ever done cadaver anatomy, you're probably familiar with this, with the infraspinatus and then the teres minor. So the infraspinatus is just below the bigger muscle there, below the spine of the scapula. The spine of the scapula is that bone, that ridge there that's dividing the supraspinatus and the infraspinatus. And then that little muscle on this side there is your teres minor. When we're looking at the other picture on the left here that has a glenohumeral ligaments, I just wanted to emphasize that because you can see the long head of the biceps, it attaches right on the superior part of that glenoid fossa. We'll talk about that on the next slide. It's in a particular spot because that glenoid, the humeral head is right there, and it's rotating, and it can pinch that biceps very easily. So we'll be talking about that with the supraspinatus as well. But the glenohumeral ligaments is a great picture of that. It's on the anterior side of the glenoid fossa, and you have these ligaments that come out that create like a bag, and it is the primary restraint against shoulder dislocations. And so that inferior glenohumeral ligament is really our problem here, because when we do shoulder dislocations and we're in this abduction extended motion, like in football when you're trying to block someone and then someone runs really fast and takes you back, that's a common mechanism of injury. There's a lot of tension on the glenohumeral ligaments, especially that inferior glenohumeral ligament, and it's a lot of tension, and that creates the subluxation or dislocation because it's not strong enough to withstand that force typically, and it will usually rupture. So taking that in the key areas of injury, think about what I just said with anterior dislocation. Is very common, very important to remember that the abduction extension mechanism and this anterior shoulder. So you think about the shoulder and its stability, we have a lot of movement. Well, when you go back like this, the anterior shoulder is extremely vulnerable, and it only has those glenohumeral ligaments. A lot of our muscles are in the posterior part. So anterior dislocations are the most common. It's most common from that mechanism, and the inferior glenohumeral ligament is our primary restraint. When we look at this first image of the arm out, it's talking about looking at the force on the shoulder. So it's a little confusing, but we talk about this a little bit in the module that when the arm is extended, it's creating a very long lever arm, right? So there's a lot, generally you would think it's more torque. And there's certainly more load on the shoulder when it's out like this, but actually the torque increases when we shorten the lever arm when we're in a throwing position because of the muscles that are now activated. So the whole rotator cuff muscles are really designed for that good rotation. And so we can generate more force in the shoulder when it's bent because of the activation of the muscles in the shoulder. And then looking at this other picture, a key area of injury is right here with shoulder impingement is a common injury. But what we're looking at is that where it says subacromial space, that muscle that runs through there is the supraspinatus. It is our main humeral elevator, and it is what primarily is really important to our throwing motion and to any kind of overhead sport of tennis, volleyball, swimming, baseball, softball, all of those types of sports is really important. And as you can see, that long head of the biceps is coming up the arm and attaching right at the top of the glenoid fossa. It's very close to the supraspinatus. So that area is where we get a lot of impingement. When that supraspinatus is getting pinched from either that acromion, that subacromial space has gotten smaller now. So the supraspinatus could be inflamed. That space could be smaller. Sometimes people's acromions are hooked. There's a lot of reasons why that space might be smaller. And if it is, that supraspinatus will become weakened and injured. And when that happens, what muscle then acts as a humeral elevator? That is the long head of the biceps. So it's important to know that and understand that, because typically when we have shoulder impingement, we're going to see a big overactivation of that long head of the biceps, and it might be tighter than normal. For the spine, it's important to look at the spine and this curvature and know which ones are cervical, thoracic, and lumbar. So we have, so I like to think of breakfast, lunch, and dinner. So we have breakfast. We have 7 cervical vertebrae for breakfast, 12 lunchtime thoracic vertebrae, and then 5 dinner time for our lumbar vertebrae. And then we have 5 sacral and 5 coccygeal vertebrae on there. So we're looking at 7, 12, 5, 5, 4. And then when you're looking at the own vertebrae itself, know that the vertebral body is the big body. The transverse process are the ones that come out to the side. The spinous process comes out in the end. And what we need to know is that in between that space, closer to the transverse process, is where we have that pars reticularis and the lamina in that area. And the pars fractures is a common area of injury that we see. When we talk about spine movement, remember bending forward is flexion, bending backwards is extension. Then we do side bending, and then we have rotation of the spine where we're twisting. And then when we talk about key areas of injury, when this picture of the little red going through there, that is a pars fracture. We call that spondylolysis. And this is where it can come from overuse. It's typically from a lot of repetitive hyperextension. So volleyball, tennis, where we're really getting back and forth hyperextension and creating a lot of torque on that area. It's easy to miss. When that goes miss and it breaks apart, the vertebrae can then move on each other and create instability and put pressure on the spinal cord. Eventually, that is what we call spondylolisthesis. So when it separates, it's so a missed pars reticularis fracture that goes untreated can turn into spondylolisthesis. And then when we talk about different types of fractures, we talk about burst fractures. And burst fractures is when you land on your butt and it travels out and it causes that compression fracture of the anterior vertebral body. And then you can also have axial load type of fractures, which can also fracture the vertebral body but put pressure on the spinal cord itself. And then disc herniation is that picture up above. And I just want to reiterate, that is when the jelly inside the nucleus pulposus goes out into the annulus fibrosis and puts pressure on the nerves. And finally, this final comprehensive question, hopefully you just took this question and tested yourself, but I want you to not panic when you see it if you don't initially know it. Think about what is acute, what is chronic. Is it saying repetitive? Is it saying it just happened? Was it a big energy? And then think about those mechanisms. And remember, tension is typically to ligament strains like MCL, LCL, or muscle strains. Especially chronic tension is muscle strains. Then shearing, shearing, ACL, PCL, the anterior translation. I'm thinking of torsion. Anytime torsion, a spiral fracture of the tibia is a common one. Torsion isn't a common injury, but that's a common place. And compression. Anytime there's a lot of compression, we're thinking of bone, like osteochondral defects, chondral injuries, where that cartilage on the end of the bone. Or we're talking about bruises. Sometimes meniscus. And remember, pediatric is more bone than adult is more soft tissue. If you have any questions, please reach out. Please have a great time and good luck, and thank you for this semester.